Hello, this is Marquel. My topics this week are femoral anteversion and clavicular fracture. Femoral anteversion is a disorder in which the head and neck of the femur are rotated at an increased angle anteriorly in relation to the femoral shaft. This results in in-toe gating. Pathophysiology of femoral anteversion. Intrauterine pressures are increased. This results in undue pressure in areas of growth. In these cases, the neck and head of the femur is rotated inwards, which rotates the greater trochanter posteriorly. This results in in-toeing. Clinical manifestations. In-toe gating will be noticed the most when the child is running. While the child is running, they might trip or fall due to crossing their feet. There could also be a family history and a history of W sitting. This condition is most noticeable in children ages 3 to 6 and is considered normal during that time. This condition is more common in girls than boys. Femoral anteversion is usually diagnosed during a physical exam while doing an observation. Radiographs are not necessary unless surgery is anticipated. Assure the family that this condition is not harmful. The child should be observed and referred to orthopedists if medial rotations are substantial or if the parents are concerned. Non-operative management approaches are not efficient. These approaches include night splints, twister cables, and shoe modifications. Ostomy is considered when the child is 8 years or older and there is significant functional deformity and for cosmetic purposes only. Follow-up and referral. The child will need to be referred to an orthopedist if medial rotations are substantial or if the parents are concerned. The parents will need to be informed that this condition is not harmful and that there are no serious consequences of this condition. It's also important to educate the parents that the child's self-esteem could possibly be affected due to the in-toeing gait. Clavicular fractures are very common during childhood and the most common injury sustained during childbirth. In adolescence, this condition results from trauma. This condition accounts for 10 to 15% of all pediatric fractures, and they usually occur between the ages of 10 and 19 years of age. It is also the most common fracture obtained during childbirth. Birth fractures are linked with shoulder dystocia and a very difficult delivery. In adolescence, horseplay and sports injuries account for clavicular fractures. Pathophysiology. The clavicle articulates distally with the acromion at the acroclavicle joint and articulates proximally with the sternum at the sternoclavicle joint. Since the clavicle has muscular forces and several ligaments applied to its superficial subcutaneous location, it can be fractured easily. Due to the mid-shaft of the clavicle being the thinnest part and does not comprise of ligament connections, it can be easily fractured. Clinical manifestations. Clinical manifestations will vary and depend on the age of the child. In neonates, a difficult birth, a large baby, shoulder dystocia, and a mid-forceps delivery will cause clavicle fractures. The baby will be irritated when moved or lifted. In children, they will have a history of a recent fall that occurred usually on an outstretched hand. For all age groups, there will be pain with shoulder movement, decreased arm movement on the affected side, asymmetric spontaneous arm movements, associated Erb's palsy, swelling, bony abnormality, discoloration, crepitus, and callus felt over the fracture site. Plain radiographs usually confirm the clinical suspicion of a clavicular fracture. In neonates, there is no treatment needed for fractures that don't cause pain. When infants are in pain, they will become irritated when they are lifted or moved. And for that pain, immobilization of the shoulder is an option. This includes pinning the infant's sleeve to the shirt for usually 1 or 2 weeks. For children and adolescents, sling immobilization for comfort is usually sufficient for 3 to 4 weeks. A figure 8 brace if the displacement results in decreased shaft length. NSAIDs for pain, and surgery will be needed for open fractures, neurovascular compromise, and multiple trauma. Outcomes after non-operative treatment are generally excellent. Most patients do not experience any pain, discomfort, or limited range of motion. Complications are very rare. If the patients participates in sports and they're non-contact sports, they can return after 6 weeks of the injury. If they're athletes that participate in contact or collision sports, they can return to activity after usually 2 to 4 months. This is when solid bony union occurs.